All right, hi everyone. Today I will be doing an overview on von Willebrand disease based on a patient case, a patient I saw at TCI. Going over objectives, my goal for this presentation is for us to be able to explain the basic pathophysiology of von Willebrand disease, identify the different types of von Willebrand disease, just because there are multiple different types and treatment is going to differ based on those types. And then we're going to compare and contrast the different treatment and prophylactic options for von Willebrand disease. Kind of giving an idea of how this presentation will go, we'll do a patient introduction so to get familiar with the patient, and then we'll go over an overview of von Willebrand disease, so what it is, how it occurs, and then we'll go into diagnosis, just general diagnosis of anybody, and then we'll go into specifics on the patient's diagnosis. And then we'll go into treatment, so talking about the different treatment options and paths, the drugs in those treatment options, and then going over what was picked for the patient. Introducing our patient, we have LS, who is a 7-year-old boy. He presents with recurrent nosebleeds and being easy to bruise. His past medical history only includes asthma, but his family history is significant for different clotting disorders. His maternal great-grandfather had factor V deficiency, and 7 of 11 of his siblings had different clotting disorders ranging from factor V Leiden, to von Willebrand disease, or low factor VIII. His mom, I actually got to interview his mom, and so I got to learn a lot from her about LS. And so she had spoke that she was easy to bruise as well, or is easy to bruise, and she actually had hemorrhaging in her pregnancy. And then mentioned that LS's father, her husband, has a history of recurrent nosebleeds, and told me about an interesting story about his father. So he actually ended up cutting his leg with a chainsaw. It was a pretty big cut, but he actually really didn't bleed that much. It was only when they had brought him in for debridement when he actually started to profusely bleed. And she was telling me that she was telling the provider about this, and that he had mentioned, or the provider at TCI, I should say, and that provider had told her that that's pretty common with certain types of von Willebrand disease, where you have this really big trauma and you don't really bleed because you have this huge influx of von Willebrand factor coming in. But then you have this minor cut, minor injury, and it profusely bleeds because you don't have this influx of all of this factor. So I thought that was pretty interesting. Going into the pre-op lab work on the 21st, this was because LS had a planned tonsillectomy, and the surgeon who was going to do the tonsillectomy, when he heard about LS's history of bleeds, nosebleeds, and being easy to bruise, and then especially with the family history of clotting disorders, he elected to doing a von Willebrand factor assessment just to be safe. And so from this, you can see the von Willebrand factor antigen, that's the first one. It was 77%, which is normal. And then we have the von Willebrand factor risdiplam cofactor assay, which essentially just means the activity of the von Willebrand factor. And it was low at 48%. And then we have the factor VIII, which was normal at 70%. And then we have the activity to antigen ratio, which was 0.62. And then I put all of his other labs over here, but they were normal. So his APTT, his PT, hemoglobin, platelets, MCV, and red blood cells were all normal. Based on this, the surgeon, the provider, had decided, there is probably a possibility that LS has von Willebrand's, but his activity is barely below that cutoff. So kind of doing risk versus benefit with mom and talking about all of the risks that might occur, they did elect to go with tonsillectomy, just seeing what might happen. So went in surgery day, the 27th. LS did get his adenoids removed and also got a vessel in his nose cauterized to help with the bleeding, because there was a vessel that they noticed that needed cauterized. So they did that. However, with the adenoids, and once the surgeon started going to remove the tonsils, there was profuse bleeding. So when he was suctioning, there was just this watery bleeding that wouldn't stop. And so ultimately the surgeon decided to postpone the tonsillectomy. And then on the 8th, the mom and LS went in for a post-op checkup. The mom mentioned that LS had right nasal bleeding the day after, but none since. And then the surgeon decided to do a consult hematology for possible von Willebrand disease and to see us at TCI. So the patient presented to us on the 11th, and they presented to us for a desmopressin challenge in regards to a new possible diagnosis of von Willebrand disease. Now, going into that was our first overview of the patient. There'll be more about the patient later, but kind of going into von Willebrand disease, just what is it exactly? So just some background, von Willebrand disease is actually the most common inherited blood disorder. It affects about 1% of the population, and 1 in 10,000 patients will be symptomatic. And so talking about inherited, just kind of what that means, I feel like this figure right here is a very good explanation for those who like pictures over words. But so there's autosomal dominant, which means so the father here has the gene, the allele, the von Willebrand disease allele, and it can be passed on to his children. So with autosomal dominant, you only need to get one affected allele to get the disease. But if you go to autosomal recessive, you have to get both von Willebrand disease alleles from both parents to be able to have the active von Willebrand disease. So here you can see that the son here was lucky, he was unaffected, so he got normal genes from both his parents. But here you can see, because the white is the affected, so the daughter only got one von Willebrand disease allele, and the other one was normal. So she's just a carrier. She doesn't have the disease, she just carries the allele for von Willebrand's disease. And then down here, you can see that the daughter here got both of the alleles, so she has symptomatic von Willebrand disease. So she has the disease, she's not just a carrier. And the types of von Willebrand disease that are autosomal recessive are your 2N and 3, which will make sense later because the recessive types are usually more severe, and the 2N and 3 are usually the more severe diseases of the other types. And then it rarely skips a generation, but it can happen. So just being able to watch for that, because just because it is most commonly inherited, it can be acquired. So it can happen with certain disease states that we'll talk about and certain medications. And then it has been known to spontaneously occur in patients. So the allele, or there was just a spontaneous mutation that happened. And then many patients go years without accurate diagnosis and live with untreated bleeding. And the guidelines mention that there's a critical need for increased awareness and understanding of all healthcare providers and society, just because a lot of times patients feel like they're not advocated for, and they feel like they have to advocate and push for themselves a lot. One of the videos that I watched about the formation and the reason for the creation of the guidelines, one of the main spokespersons and creator of the guidelines, she actually has von Willebrand's, and her daughter does as well. And she talked about how her daughter really had to advocate for herself in a certain situation. Her daughter had recurrent miscarriages and was in the middle of one and had to go for a procedure to complete and resolve the miscarriage. And the surgeon provider had told her, no, you don't need prophylaxis, we'll be fine. We can just go in, we'll do the surgery and you'll be fine. You don't need to worry about prophylaxis. And the daughter said, no, I need to have the prophylaxis or I'm going to bleed. I have von Willebrand's disease. And he kind of dismissed her and pretty much told her no. And so ultimately she had to advocate for herself and go to a hematologist who agreed with her and said, yes, you absolutely need prophylaxis for the surgery to make sure that you're safe. And so luckily, due to her advocacy for herself, she was able to get prophylaxis. So that's why I feel like this is really important to talk about and know, because even though it is only 1% of the population, it's still a lot of patients, and we need to be able to advocate and know the resources to be able to help them. And then, like I said earlier, there are multiple types of von Willebrand disease, but type 1 is the most common. So going over the pathophysiology of just what is von Willebrand disease. So it is a disease of the von Willebrand factor. So a lot of guidelines and places explaining about what von Willebrand factor is kind of called it the glue of the platelets. So what it is it's a bridge between platelets and the vascular endothelium. And then there are different molecular weight forms of von Willebrand factor. You have low, intermediate, high, and ultra large molecular weight forms. And then the higher you go in the forms, so high and ultra large, they have stronger capacity and ability to bind with the platelets. And then that'll be important as we talk about the different types of von Willebrand and mutations in them. And so von Willebrand factor is dimerized, multimerized in the Golgi apparatus, and then it's sent out into the plasma, or it's stored in Weibel-Palade bodies, which is denoted as WPB, and that'll be important as we talk about the mechanism of action of one of the drugs because it works with the WPBs. And then, so it helps with adhesion and promotion of aggregation as well. So it allows platelets to bind together. So kind of explaining that a little bit. So you have an injury here. So you have an injury to your vessel, and your von Willebrand factor is going to go and bind to the collagen outside in your connective tissue. And when the von Willebrand factor combines with the collagen, you have platelets come and bind to the von Willebrand. So you can see here, the platelets bind at the GP1B receptor, and they bind to adhere to the von Willebrand collagen. And then from this, you have activation. So with your platelets binding to your von Willebrand factor, you have activation, which increases the surface area of the platelets and causes release of granules. And there's two main types of granules that are important. You have alpha granules, which releases fibrinogen and more von Willebrand factor. And then you have dense granules, which release ADP and thromboxane, which will activate more platelets and constrict more and just pull more platelets in to help form a clot. And then after, you have aggregation. So here, ultimately, you have fibrinogen converting into fibrin. And from that, the platelets come in and attach to the fibrin to put together this dense, stable clot. And an important part of it as well is the von Willebrand factor binding to the fibrinogen. It's important because then it helps make a stable clot as well when that fibrin is formed. And so you can see here with the aggregation, the von Willebrand connects the platelets with the GP2B3A there. And that probably sounds familiar because there we do have targets, antiplatelets that target this receptor right here. So that is how von Willebrand factor works and connects with aggregation and adhesion to injuries that we have. And then kind of just a very quick overview of the domain. So this is a layout of von Willebrand factor. So the main ones that they know most about is A1, A2, A3, and D3. So you have A1 here. So it binds von Willebrand factor to platelet GB1B. And then you have A2, which will be important as we talk about different disease subtypes and drugs that may cause acquired von Willebrand disease. So A2 is the cleavage site with ADAMTS13. So you can see that here. So it causes proteolysis, so breaks up the von Willebrand platelet connection. And then you have A3, which is von Willebrand factor collagen connection. And then down here, you have D3, which is the von Willebrand factor binding to factor 8. And then this is just a basic quick look at another important reason for von Willebrand factor. So it is actually a carrier for factor 8. So that's why factor 8 was drawn to be looked at, because von Willebrand factor has to carry factor 8, because if it doesn't, factor 8 is going to be broken down quickly and cleared, and it's not going to be active. So kind of looking at this, we can see that von Willebrand factor is important for both platelet and coagulation factor mediated homeostasis. So it works on both ends. So that was a lot about pathophysiology. So now going into the diagnosis and how that plays into the pathophysiology. So we have 3 different types. We have type 1 von Willebrand disease, which I said was the most common. So it's a partial deficiency in von Willebrand factor. And then there's actually a subtype, type 1C, which is increased clearance of von Willebrand factor. And then we have type 2, which is just all of the subtypes are qualitative abnormalities of von Willebrand factor. So you have von Willebrand factor, but it's just not working appropriately. And so this is where that pathophysiology knowledge is important. So 2A, we have a reduction in the high molecular weight von Willebrand factor multimers. So like I said, the high molecular weight multimers have stronger affinity, stronger binding. So when we lose those, we lose the strong affinity, strong binding. So we have more weak binding. And so we don't have as stable of clots. And then 2B, we have increased binding to platelets, which I thought was interesting because you would think increased binding to platelets, wouldn't it be increased risk of clotting? So with this actually, so you do have increased binding of von Willebrand factor to platelets, but it's attaching at the wrong time. So there's no injury. So you have this binding, and then the body notices all of these platelet von Willebrand connections, and it clears it. And so when you actually do need these connections to be made, you don't have enough platelets or von Willebrand factor to bind to each other. And so that is why this results in von Willebrand disease. And then also these patients end up losing high molecular weight multimers. So there's two different scenarios going on there with type 2B. And then with type 2M, we have decreased binding to platelets, so opposite. And then 2N, decreased binding to factor 8. So factor 8 is quickly destroyed. And then type 3 is actually very rare, and it's barely mentioned in the guidelines. They just mention it to just say what it is. It's not in, as you'll see in a few slides, it's not even on their diagnosis algorithm. They just talk about what it is, and they don't really talk about how to treat it either. So it is a total deficiency of von Willebrand factor and also decreased factor 8. And looking at this, you'll see that type 1 and type 3 are quantitative forms of von Willebrand disease. So there's actual decreases of the factor, but type 2 is more qualitative. So there's just issues with the factor. And just a quick overview of acquired von Willebrand disease, just to kind of show you that this is a thing and something to watch out for, especially since we are the drug experts. And so since some drugs can cause it, just being able to know that. But the reason, won't be going very too deep into it, is just because a lot of times when these diseases are treated or these drugs are stopped, the von Willebrand disease goes away, which is good. But so with hypothyroidism, as we know, thyroid hormones are important for activity and energy and creation of a lot of different organism or pathways in our body. And so if you have low T4, you're going to have less production of von Willebrand factor. But once you treat that hypothyroidism, ultimately your von Willebrand factor will go up, and then you won't have von Willebrand disease anymore. Then there's also some concern with autoimmune diseases causing von Willebrand disease, and this is thought to be due to autoantibodies against the factor. And then lymph, plasma, and bone disorders are the most common associated condition with acquired von Willebrand disease, but they're unsure of the prevalence in these disorders and the actual connection. They just noticed that most people with acquired von Willebrand disease had one of these disorders, but they're not sure the actual connection. And then another, solid tumors. So Will's tumor, it's very common to have acquired von Willebrand disease. So a lot of times they'll actually test patients for this. But ultimately, once patients are treated for their tumor, the von Willebrand disease usually resolves. And then ventricular assist devices are also associated with acquired von Willebrand disease. And so this is where that site A2 comes into play with the ADAMTS13 and the cleavage. So first you have stress from this device that can cause damage to your von Willebrand factor. And then also they talked about you have this increased platelet binding, and ultimately it enhances that cleavage of von Willebrand factor. And so it causes increased bleeding that way. And then just quickly going over the drugs, there are multiple other drugs as well, but these were the only two that actually had a mechanism pathway for why it caused acquired von Willebrands. So that's why I put them in there. There was another drug too, grisefolvin, but they didn't say why it caused or how it did, so I didn't want to put that in there. But ciprofloxacin, it accelerates the proteolysis, so accelerates that ADAMTS13, and then valproic acid decreases von Willebrand factor formation. But ultimately, when these drugs are stopped, usually it resolves and they don't have von Willebrand disease anymore. So it's a transient effect. Going over presentation of the different types, most common, your patients are going to present with frequent nosebleeds, bruising, bleeding from small wounds or minor procedures, and very severe cases, you'll have bleeding into the joints, which is something I believe you see usually like with hemophilia. And then in women, just kind of to mention that, it's usually you see heavy menstrual bleeding. So kind of watching that in women or young girls. And then going into the different types presentations. So type 1 and even the subset 1C, you have mild to severe or even some asymptomatic patients. And then type 2, you have qualitative abnormalities of von Willebrand factor. And so 2A can have mild to moderate bleeding, 2B, moderate to severe bleeding, or even thrombocytopenia, which is due to that increased platelet binding. In 2M, you can have significant bleeding. And then 2N, you can have joint and soft tissue bleeding, which is also pretty severe. And then type 3 is severe bleeding and joint or soft tissue bleeding as well. So this is straight from the guidelines from the ASH 2021 guidelines on the diagnosis of von Willebrand's disease. I will be zooming it in so we can kind of see specifics and follow it through that. As you can see, like I said, there's no type 3 on here, but I did mention it for completeness sake, so we do know that it is a thing to watch out for. And so all of these yellow numbers, yellow circles with numbers, they are references to guideline questions and the evidence for the flow chart. But as you kind of start getting down into like 3, 4, 5, I feel like the way my brain works, they don't line up to the question necessarily. I feel like they're one off. Like I feel like 4 matches better with 5, but when you read the guidelines, you can see that. But I'll just be following the flow chart and kind of going over that to explain how all of this works. So first, going into the beginning, if you're in the primary care setting and you suspect that a patient has von Willebrand disease, you want to do a bleeding assessment tool, which they call a BAT. And there are 2 different types. There's an ISTH BAT, and then there's a self BAT, so one that the patient can do themselves. And it's important to know, it gets kind of confusing, so that's where this little 2, the asterisk, comes. So recommendation 2 in the guidelines, they talk about that BATs have the most evidence as a screening tool in adult women. So if you have a male patient, a child, there's not a whole lot of evidence for BATs. And so ultimately you just want to go straight into doing your labs. So your CBC, your PT, your von Willebrand factor assessment. You want to go straight into that just because the BAT might miss some patients. And they also talk about too, if you're the hematologist, they got referred to you, you don't want to do a BAT. It's not going to be an effective tool. And so you just want to go straight to the von Willebrand factor assessment. And then if a patient has a first degree relative affected with von Willebrand disease, you also want to avoid the BAT, just go straight into von Willebrand factor assessment. And with that, so if you're in the primary care setting, it's a woman, and that's the most evidence for it. It's negative, normal bleed score. You can rule out von Willebrand disease, but most of the time, just if you have any doubt, any suspicion, just going straight to this, better to test and see, that it's not, than to rule it out and then them ultimately have it. And then down here, there are a lot of acronyms for a lot of different things. And so I put them here, and then there'll also be a slide at the end that goes over all of them as a reference. So like I had said earlier, the VWFAG, the von Willebrand factor antigen, and then we have platelet-dependent von Willebrand factor activity. So ultimately the activity level, and they actually prefer the drawing of platelet-dependent von Willebrand factor activity, but a lot of places don't have that, especially in the US, it sounded like. So a lot of people do what was drawn for LS that first time, which was the von Willebrand factor ristocetin cofactor assay, which, like I said, is pretty much just the activity of the von Willebrand factor. So that one's used a lot, but the guidelines mention not really referring that one as number 1 because it can lead to misdiagnosis or wrong classification. And then we have the factor 8, factor 8 coagulant activity. So the ability of the factor VIII to bind to the von Willebrand factor. And then, so that is some of the tests there. And so that's the beginning part of the diagnosis process. And then here, so you draw the von Willebrand factor assessment. Their levels over 50, you're going to rule out von Willebrand disease. If their level is between 30 and 50 and they have no bleeding, most likely rule out von Willebrand disease. But if they have bleeding, that's when you're going to go. So here it says the platelet dependent von Willebrand factor activity. But if you can't use that one, then you go to the risk of CTAN, so the RCO and von Willebrand factor antigen ratio. And if you're less than 30, you go straight to there anyway. And so if your ratio is over 0.7, you're going to go down to your type 1 von Willebrand disease. You're going to do a DDAVP trial, which we'll go into next, which is a desmopressin trial, because with desmopressin, you want to do a challenge to make sure that they respond. And then this can lead down to type 1C von Willebrand disease. And I feel like here the guidelines get a little, I feel like can be misinterpreted or misleading, I guess would be the right word, because you see this positive here and you assume, okay, they're positive, so they're 1C. That's not necessarily what that means. So with 1C, what you'll see with the desmopressin challenge is, so we draw at certain times. So we draw before the desmopressin, 1 hour after, and then 4 hours after. And so what they mean by positive is at 1 hour, you're going to have this really high increase of your antigen. But then you, at your 4 hour draw, you're going to be back at baseline. You're going to be back at normal. It's not going to be elevated anymore. And that's how you know you have 1C, because 1C, like we talked about earlier, is increased clearance of your von Willebrand factor. So your body clears it more quickly. And so that's why that second 4 hour test is important. And then here, when their ratio is less than 0.7, you're going to want to go to your type 2 von Willebrand disease. But this is kind of also confusing and misleading of the guidelines as well, because they talk about, and other resources talk about as well too, just because it's less than 0.7 doesn't mean you necessarily immediately rule out type 1. And so you'll kind of see that with our patient a little bit. I don't want to ruin anything, but you'll kind of see why it's confusing and misleading there. And then, so you're diagnosed with type 2. So going down, how do we figure out what type of subtype of type 2 do you have? So that's when you look at your VWF-CB, which is your von Willebrand factor collagen binding. So your ability of von Willebrand to bind to collagen, but it's a substitute for multimer testing because it's debatable how well the collagen binding test is. So if you can, looking at the multimer, so just looking at your high molecular weight multimers is essentially what they're looking at to be able to distinguish, do you have type 2A or B, or do you have type 2M? So if they're abnormal, you're going that 2A, 2B route. If it's normal, you're going the 2M route. And then, so if it's abnormal, to be able to distinguish between A and B, you need to do genetic testing. And then they also talked about too how you can look at von Willebrand factor platelet binding, so VWF-PB. And so if you have an increase in spontaneous binding, that can also be 2B. But genetic testing might be the easiest, best way to go. And then if you have less factor VIII than von Willebrand factor, you're going to go look at your von Willebrand factor, factor 8B or genetic testing to confirm your 2N subtype. And so what this von Willebrand factor VIII ratio is it looks at von Willebrand factor's ability to bind to recombinant factor VIII to confirm 2N, which shows a defect. So if there's a defect, you're gonna go the 2N route. And something else they add here too is sometimes von Willebrand factor can normalize with age. It's normal for von Willebrand factor to increase with age. So they talk about this possibility of reconsidering diagnosis, but really they say, you know, you really need, it's a patient-provider relationship. So kind of sitting and going over, you know, what's the risk, what's the benefit, just because, if you remove this, they have a surgery, they end up having a bleed, that can be pretty severe and that can be detrimental. So just kind of deciding, do we want to leave it just in case, or, what's going on? So just really thinking about that before you remove that off of someone's profile. And so, like I said, the desmopressin challenge is really important. So with that, you do 0.3 micrograms per kilogram of DDAVP with a max of 20 micrograms. It's in 20 mils of NS. It's infused over 15 minutes. You want to monitor blood pressure and adjust for hypotension. And then you also want to counsel on temporary flushing, mild headache, and mild water retention, which I got to go and watch LS's infusion for a little bit, and he actually did end up having flushing. I don't know if he had a headache, he never said, or if he had any water retention after, but I did notice the flushing, and he seemed unfazed by it. So I guess, hopefully, nothing patients notice. But with that, it's important to know that you have to draw the labs before the infusion, and then you draw it again 45 minutes after the completion of the infusion, which we do at TCI. The only one we don't do, the guidelines talk about, is the 4-hour post-infusion. And that's really to help, like I said, distinguish between the type 1 or the type 1C. And then with the labs, they're obtaining a CBC, platelet, and von Willebrand factor activity and factor VIII activity. And then to be able to say someone has a positive desmopressin challenge, it requires a von Willebrand factor rise over 30 or over 50. And then it talked about if you suspect that your patient has 2B, you don't want to do this challenge just due to the thrombocytopenia risk. So being careful in those patients. All right, so now application time. So as we go into this, so our patient LS, he underwent a desmopressin challenge on the 11th when he came to us. He got 9.36 micrograms and 50 mils of NS over 15 minutes. And then these were his results. So looking at this, so this was his pre-desmopressin levels. So his activity levels, 80%. His antigen, so his just factor levels were 89. His factor VIII levels were 85%. And then his activity antigen ratio was 0.89. So I don't know if you remember his levels for when he was going for his surgery for tonsillectomy, but these are a lot higher. And so that may make you start making you think, well, does he really have von Willebrand disease? Kind of what can happen. But it's important to know in stressful situations, or if someone's sick, or if someone, like him in the situation, he's probably, getting a lot of lab draws, and he's in a new place. And so stress can, and situations and sickness like that, can increase our von Willebrand factor. So kind of trying to keep that in account. It could have just been due to the setting and kind of the environment and the stress of all of that increased it. But you can see here that his activity antigen ratio went from, I think his one was 0.6 and now it's 0.8. And so that's important if you remember back to the guideline flow of distinguishing between two different types. And so thinking about this, just wondering, was this a positive desmopressin result? And then what type of von Willebrand disease does this patient have? And so kind of thinking about that, what you guys think. All right, so from this, the provider concluded that this was a positive result. So the patient responded to desmopressin. And then from this, it was decided that the patient has type 1 von Willebrand disease based on his pre-op levels of 30 to 50, the history of bleeding, and then the ratio here being over 0.7. And then so going to type 1 von Willebrand disease. And then since we don't have the 4-hour post-infusion, we can't really tell if he has type 1C or not, which I feel like is important because I don't know if I mentioned it before, but if you have type 1C, desmopressin is not going to work for you as prophylaxis just because your body clears that von Willebrand factor so quickly that desmopressin isn't going to be an option in those patients. So, going into the treatment, for von Willebrand disease, for a minor surgery, which is designated as a simple tooth removal and other outpatient procedures not specified under major, which we'll go over what majors are, you want to get a von Willebrand factor level at least 0.5 or more with desmopressin if they're responsive, or factor concentrate with addition of TXA, which TXA is tranexamic acid. And so TXA alone is preferred in patients with type 1 von Willebrand disease with a baseline level over 0.3 and mild bleeding phenotype undergoing minor mucosal procedures. For major surgery, this is going to be any CNS surgery, opening large body cavities, severe hemorrhaging is possible. You're working in the joints, you have a third molar extraction, so more complex tooth removal, or the patient's life is at risk, so they're very unstable. You'll want to target the factor 8 level and von Willebrand factor activity levels at 0.6 or higher within 3 hours of surgery, and then you want to keep it 0.5 or higher for at least 3 days after surgery. And then in major surgeries, you want to avoid DDAVP. So you want to go more to the factor concentrate. And then here I went over a little bit, just it's kind of outside of our patient, but menstrual bleeding, they prefer hormonal therapy or TXA over desmopressin. And then if a patient is wanting to get pregnant, preferring TXA over desmopressin. So that's the preference there. And then they may need additional treatment the first few months after starting therapy to build it up and prolong after. And then neuroaxial anesthesia, you're going to want to target the von Willebrand factor of 0.5 to 1.5 during and 6 hours after removal. Postpartum management, you're going to do TXA oral or IV, 25 milligrams per kilogram, 3 times a day for 10 to 14 days or longer if the blood loss is still heavy. And then for blood clots, it was an interesting concept, and there's still like a little bit of back and forth about it, but ultimately they prefer treatment of the clot over no treatment at all, and just really doing a lot of risk versus benefit and increased monitoring to make sure that there's no bleeding. And then going into the specifics about the drugs available. So the first one, desmopressin, which we've talked a lot about already, DDAVP, or the nasal version is Stimate. And the indication is minor bleeding or before minor surgery. And then the MOA you can see here. So when I talked about the WPBs, this is when it comes into play. So it is a V2R agonist. So it stimulates release of the von Willebrand factor. So it is stored here in the WPBs. And this activation here releases the von Willebrand factor from the stores. And like I said, it requires a challenge to ensure adequate response. And it is used in types 1, 2A, M, and N. And adverse events to watch out for, because it is a potent diuretic, is going to be hyponatremia, edema, and seizure risk due to the hyponatremia, especially in children. You really want to watch out for that. And then just making sure to restrict fluid just because it can cause the fluid retention. And then luckily here, the adult and pediatric dosing are the same. So you have IV or sub-Q. It's 0.3 micrograms per kilogram once with a max of 20 micrograms. You do it 30 minutes before surgery, and it's only for those 3 months and older. And then the intranasal version is 2 hours before surgery, and that's for those 11 months and older. And if you're less than 50 kilograms, you're going to do 150 microgram, so 1 spray in 1 nostril. But if you're 50 kilograms or more, you're going to do 1 spray in each nostril. So a total of 300 micrograms. And it's important to use it 3 or less consecutive days just because tachyphylaxis can occur. And so we don't want that to happen. So we want to try and limit our use. And so it talked about if you're needing it more often, the best response is usually taking it every 2 to 3 days. You don't want to take it daily for more than 3 days. And then, like I said, it's not great for 1C, just because you'll have decreased half-life of von Willebrand factor due to the increased clearance of it. So just being aware of that. And then we have aminocaproic acid. Its indication is for bleeds and surgical prevention. It binds, as you can see here, to plasminogen. So it blocks the formation with fibrin. So it prevents plasmin conversion. So the fibrin clot is not broken down. And then adverse events from this, it's usually normally well tolerated. I had to really dig to find some side effects that can be seen or common. So something that is concerning that you would want to watch out for is intrarenal obstruction. So in patients who have urinary bleeds, you're not going to want to go with this drug just because of clot formation that could occur there, that could increase BUN and cause obstruction there and cause kidney damage. And then arrhythmias can sometimes happen, tinnitus, VTE, and stroke risk are of course a thing just because you are promoting clot formation. And then with the adult dosing in LexiComp, they talked about it being adjunct with factor replacement for mucosal bleed. So doing 50 to 100 milligrams per kilogram every 6 hours until healed or bleeding stops. In the pediatric, the dosing was the same, but they just said prevention of bleeding after surgery. So 50 to 100 milligrams per kilogram per dose every 6 hours with a max of 24 grams per day. And then they mentioned too that you can use desmopressin or factor replacement for 7 days or until healing is complete. And with this, a lot of different resources talked about. It's really important to have this as adjunct therapy just because you need that factor to come in at first. So resources and guidelines talked about maybe just doing factor replacement on the first day to promote von Willebrand factor surplus and getting those clots started to form. And then this aminocaproic acid will come in and just keep those clots stabilized. So factor comes in, helps to form the clots, aminocaproic acid keeps the clots there. And then kind of very similar, we have the tranexamic acid, so TXA, and then its indication is for bleeds and surgical preventions as well. And it displaces plasminogen from fibrin as well, so preventing the breakdown of fibrin clots. And then this one had more side effects and warnings. So intrarenal obstruction, same as before, so not using in urinary bleeds for the same reason. It can cause visual defects, so watching out for that. It can cause thrombotic events, and it can even cause seizures or myoclonus in some patients. So we really want to be watching out for that in all of our patients. And the pediatric adult dosing was the same. So it's adjunct therapy with factor replacement. And this was specific for tooth extractions, but it can be extended to after surgery. So IV 10 milligrams per kilogram of actual weight given 2 hours before at a rate of 100 milligrams per minute or less. And then you give them 10 milligrams per kilogram 3 to 4 times daily for 2 to 8 days. However, once they're stable, you can transition them to oral so they don't have to keep coming in or stay for an IV infusion. And then the oral dosing is 25 milligrams per kilogram given 2 hours before, and then 25 milligrams per kilogram 3 to 4 times daily for 7 to 10 days. And then the last drug that we have is the von Willebrand factor concentrate. So there's different kinds. There's the recombinant, which is just von Willebrand factor. And then we have von Willebrand factor with factor 8. And so those are here. So they combine the 2 different forms. You have humate-P, willate, and alphanate. And alphanate is only for those 7 years of age and older. And these are the ones for children. The recombinant, your von Winde, is only for adults, so only those 18 and older. And then kind of going into who these are used for, these are most commonly used for 2B and 3 because these types can't use desmopressin. And then it's also saved for those who failed desmopressin. And it is actually approved for prophylaxis in type 3 twice weekly, which will go into that dosing in the prophylaxis section next. And then it's important to know too that humate, willate, alphanate, von Winde, these products are not interchangeable, so you can't interchange them. And then with monitoring, you want to monitor the peak and trough at least once. You want your trough over 50, but you don't want your peak to go over 200 because the high end of normal is 200. And when we say peak and trough, this is of your von Willebrand factor antigen. And then, so for a minor surgery or minor bleed, for either of the types of factors, all of the dosing is the same. You're going to do 30 to 60 von Willebrand factor ristocetin cofactor assay units. So it goes based off activity units. per kilogram as the loading dose. And then you want to do 20 to 40 units per kilogram every 12 to 48 hours as maintenance for 3 to 5 days. And then for a major bleed or surgery, you're going to do 40 to 60 units per kilogram. And then after for maintenance, you're going to do 20 to 40 units per kilogram every 8 to 24 hours for 7 to 14 days. And then this picture right here was just the Hum8P, just showing just 2 different types. And then going into prophylaxis. So long-term prophylaxis is needed in those with severe and recurrent bleeds. Long-term prophylaxis is defined as a period of use for at least 3 months and at least being once weekly. So for adults only, your Von Bindi is an initial 40 to 60 units per kilogram twice weekly, may increase to 60 units per kilogram twice weekly if breakthrough bleeding into joints or severe bleeding. With your adults and pediatrics, your Will8, this is actually approved in Will8. It's 20 to 40 units per kilogram, 2 to 3 times a week, depending on response. And then with your Hum8P and Alphanate, this is more off-label. It's 40 to 60 units per kilogram, 1 to 3 times a week, or every other day, depending on response and severity. So probably starting at that, 1 time a week, they're still having bleeding, increasing to the 2. That's not working, increase to 3, it's still not working. Then we go to the every other day. So we want to start low and go high. And then we have another application time. So ultimately, the patient's management plan. So the day that they came in to us for the desmopressin challenge on the 11th, he was prescribed aminocaproic acid, 0.2 grams per mil solution. He was told to take 6 mils, 1,500 milligrams by mouth 4 times daily until bleeding stops, and then take it 2 to 3 days thereafter the bleeding. And then after the positive desmopressin result and figuring out what type he had, they were able to make a tonsillectomy prophylaxis plan. So they decided pre-op to go with desmopressin 0.3 micrograms per kilogram, so a dose of 9 micrograms IV over 15 minutes. And then post-op to prevent bleeding after, going with the aminocaproic acid again, 100 milligrams per kilogram, take 6 mils, so the same, 1,500 milligrams, 4 times a day by mouth until post-op day 10 or as directed. So based on response, he might go longer. And then they did note that he may repeat a desmopressin dose post-op days 7 through 10 if they're anticipating bleeding or if they're having bleeding. And then if there's emergent bleeding, they have fresh frozen plasma ordered, 10 mils per kilogram, so 250 mils of fresh frozen plasma if there is an emergent bleed. And then, so that was a lot of information and a lot of results and diagnoses and treatments and kind of a review of this. So von Willebrand disease can be the results of low levels of von Willebrand factor or defective factor that results in inadequate adhesions and aggregation of platelets. And just knowing von Willebrand factor is like our glue for clot formation. So we need it for our platelets to connect together and for our platelets to connect to our tissue, our collagen. And then just knowing von Willebrand disease is diagnosed based on quantitative or qualitative defects. So your quantitative again are your types 1 and 3. So those are actual low levels of von Willebrand factor. And then your qualitatives are your type 2A, 2B, 2M, and 2N, which is defects in your von Willebrand factor. And then just knowing treatment and prophylaxis will depend on the injury or surgery. And it's kind of up to provider, up to the hematologist, dosing and drug choice. It's kind of all over. The guidelines they're specific, but not specific at the same time. They only mention aminocaproic acid once actually. But as you can see, the provider used aminocaproic acid in each situation. And so I feel like it has to do a lot with, history with the provider and what's worked with them. And based off of that, and so just knowing, don't use desmopressin unless you have a positive challenge. And then you have tranexamic acid or aminocaproic acid, which are kind of the same thing because they both work the same way. And then you have von Willebrand factor replacement, either the recombinant if they're 18 and older, or the von Willebrand factor 8 combined treatment. And then just knowing lifelong prophylaxis is just only the von Willebrand factor replacement. And so, like I said, down here is just an abbreviation of and explanation of the abbreviations for a quick referral. And these are my references. And I know that was a lot of information. And so if you guys have any questions or concerns or any clarification, please let me know. And thank you.